So Module 2 presents a more detailed look at some of the major issues in global TB care and control. These data come from a number of different sources and are much more specific and get to very important questions that have arisen during the course of collecting some of this information. The problems that have emerged are, first of all, that there is more tuberculosis than previously estimated. That, as I've already said, there's little or no information on about 40% of the estimated cases, that 4 million missing case gap that I showed you. Importantly, and related to this 40% gap, engagement with private medical providers is really quite limited. And the thinking is that many of these 4 million cases that comprise the gap between the reported and the estimated are actually in care in the private sector, but without notification of the cases to public health authorities. As we'll see, and I'll show you data to this point, many cases do not have typical symptoms. Cough has been the symptom that we generally relied on to indicate the need for an evaluation for tuberculosis. In many cases, it's been found actually do not have cough. The major diagnostic test that's used globally for diagnosis of pulmonary tuberculosis performs very poorly. This has been known for a while, but the studies that have been done in many different countries now show that test performance is really suboptimal, both in terms of sensitivity and specificity. And now again, I'll show you the data. Access to care is limited by geographic, financial, and social barriers, so that patients who have cough, who have something that should be evaluated because it's possibly caused by tuberculosis, often do not have the access to care that they need for the full evaluation. That there's increasing recognition of comorbidities, and these comorbidities require more integrated care. Maybe the best, most dramatic example is HIV infection, where persons with HIV infection have a number of additional comorbidities, as I'm sure you all know quite well, and these require a comprehensive program of management. That MDR-TB is increasing, but access to both diagnostic services and treatment is limited. And so we're doing very poorly at both identifying and successfully treating patients with MDR tuberculosis in many parts of the world. And finally, preventive measures, both infection control in facilities and the use of treatment of latent tuberculosis infection are rarely used in most parts of the world. So let's move on to look at the data that from which these conclusions have been drawn. Most of this comes from tuberculosis prevalence surveys that have been conducted by the WHO Global Tuberculosis Program, this unit being led by Catherine Floyd. And these surveys have been conducted almost entirely in Asia and Africa, because that's where, as you saw in the earlier slide, the problem is greatest. This shows the prevalence surveys that have been done since the early 1990s. We'll be focusing on those that have been done since 2009 to up through 2016. So first, as stated in the problems identified, these prevalence surveys have shown that there is considerably more tuberculosis in many countries than has been estimated. If you, these are two panels representing prevalence studies done in Africa on the left and Asia on the right. And you can see that the blue bars, which represent the estimates prior to the prevalence surveys, generally reflect lower numbers than the red bars, which are the estimates derived from the prevalence surveys. And in some of these, it's quite a substantial difference. I should point out that the scale at the bottom is a log scale, not a linear scale. So you can't just look at this and say, well, it doesn't look that much higher. In fact, because it's a log scale, it is quite substantially higher for example, the Tanzania data or Malawi, Ghana, Kenya, Nigeria, Zambia, and Uganda. Cameroon, I guess, has not had a prevalence survey done. For the Asia studies, the most recent one that has been completed is the Philippines and shows a much higher prevalence of tuberculosis than had been estimated. Likewise with Laos, Indonesia, the number of cases in Indonesia is about 3 times higher than previously estimated, and so on down the list there. In some instances, the prevalence surveys showed that the number of cases was actually very close to the previous estimates, but what is quite striking is the number where the actual measured prevalence from the survey was quite substantially higher than the previous estimate. This just looks at how this translates into incidence. This looks at select countries, both in Asia and Africa. And what we see here, taking Indonesia, for example, is that the number of notified cases per year, actually this 2015 data, was just over 300,000. But the estimated number of cases based on the prevalence survey occurring each year is just over 1 million. So a 32% case notification rate, or a gap of 68%. That is 68% of the cases in Indonesia were not reported, and there's little or no information relating to the status of those cases. Looking at Nigeria, number of notified cases, 90,000. The estimated number was 586,000. That leads to a 15% case notification rate, meaning 85% of the cases have no information known about them. Just to look at another recent survey in Kenya, this is from the actual Kenya report that says there's more TB in Kenya than we thought. The 2015 WHO estimate was 233 per 100,000 population incident cases, and the prevalence survey showed that the prevalence was actually 558 per 100,000 population. This translates to about 138,000 incident cases per year based on the 558 prevalence survey estimates, compared with 82,000 cases reported in incident cases reported in 2015. So approximately 40% of the cases in Kenya have no information known about them. This is, I think, a particularly important data display. What this shows is it's a complicated slide, but in the upper panel, the data from Africa are represented. In the lower panel, data from Asia. In the right-hand panel represent cases that are smear positive. In the left-hand panel, smear positive cases. The right-hand panel, those that are culture positive, that include the smear positives. What you see on the x-axis is the proportion of persons who had radiographic abnormalities and bacteriologically proven tuberculosis who had no cough. And you see here that there are very few situations, very few countries, very few surveys in which fewer than 20% had no cough. So a substantial number of the patients who were proven to have tuberculosis in these surveys did not have cough on closed questioning. Some as high as 80% of bacteriologically proven cases in Asia did not complain of cough. So this is a significant problem in that the recommendations, by and large, have focused on cough as the key symptom and as the criterion for conducting an evaluation for tuberculosis. That no longer seems to be as solid a bit of advice as we previously thought. The sensitivity of smear microscopy we've known was not good. We've known that for a long time. It's been estimated that by and large, smear microscopy was about 50% sensitive. That is, if you use the denominator of all culture positive cases, about 50% were found to be smear positive. What these data from the prevalence surveys shows is that there's great variability among countries with a broad range of sensitivity from around 30% to around 60%. And what you see here is the red bars represent the proportion of the cases that were smear positive. The full length of the bar, the red and blue bar, indicating the total number of cases that were bacteriologically confirmed by culture, or in some cases by a rapid molecular test. So the sensitivity of smear microscopy is not good. We've known that, but we haven't recognized just how variable the sensitivity is. The other finding from the prevalence surveys that I found particularly disturbing was the frequency of false positive smears. The red portion of these bars represents the percentage of cases that had positive smears, but then did not have positive cultures. They did not meet the definition of cases, the red portion of the bar. So that ranging from about 5% in Mongolia that were false positive up to over 80% in Zimbabwe of the positive smear results were falsely positive. So this says that the smear is not only insensitive, it's non-specific as well, which is an important observation and I think has not been widely publicized. These are the diagnostic tests we use for tuberculosis. In the upper left-hand panel is a Zio-Nielsen stain, acid-fast stain, showing the typical morphology of Mycobacterium tuberculosis. You see there, sort of in the center of that microscopic field, these curved red rods. That's a typical appearance for Mycobacterium tuberculosis. In the middle panel, you see a microscopic field with fluorescent staining so that the organisms stand out much more clearly against this dark background. In the right-hand panel, you see culture on Lowenstein-Jensen solid media, and there are cultures of Mycobacterium tuberculosis as well as a number of the non-tuberculous mycobacteria, just showing their differences in appearance. In the bottom left-hand panel is the BACTEC machine. This provides liquid culture with automated reading, and this is now the gold standard for culture for mycobacteria. And then in the lower right-hand panel is a 4-module gene expert machine. This is a rapid molecular test that is both highly specific and highly sensitive in diagnosing, in identifying Mycobacterium tuberculosis, and at the same time providing one with an indication of whether or not the organism is susceptible to rifampicin. And it's assumed that in specimens that are rifampicin resistant, multiple drug resistance exists and the patient should be treated with an MDR regimen. So this is one of several rapid molecular tests that are on the market. This is probably the most widely deployed of those tests and has proven to be highly useful, but implementation of GeneXpert has been limited somewhat by price, although the price has been greatly reduced, and deployment has not been as widespread as I think it should be. And I'll come back to that point in a bit later as well. This is a systematic review that shows the results of studies looking at the sensitivity and specificity of Expert in detecting both Mycobacterium tuberculosis and rifampicin resistance. The first dot there, the first bullet, shows the data when the test is used as an initial test, replacing smear microscopy. The sensitivity was found to be 88%, specificity 98%. This is using culture as the gold standard against which the performance of GeneXpert is compared. Looking at specimens that are smear positive and culture positive, you see that the sensitivity is 98%. Smear negative culture positive specimens, the sensitivity drops a bit to 68%. Although there are some data from the prevalence surveys that suggest that, in fact, the rapid molecular test may be more sensitive than the culture, but that has not been substantiated in careful clinical studies. And then finally, for the detection of rifampicin resistance, the sensitivity was found to be 94% and the specificity 98%. So this is a very good test. The problem is that it does require more infrastructure, certainly more infrastructure than sputum smear microscopy, and a bit more training, but it provides an answer much more quickly than culture, and also with the same test provides an indication of drug susceptibility. Let's look now at some other data that are not from prevalence surveys, but begin to look at how patients actually get into care and how they progress through the care cascade. Here's some data from India that used modeling of the care cascade, but based on some real data. The first bar shows 100% of the prevalent cases in India that I showed you earlier was, this is the number of cases per year, not just prevalent, but 2,700,000. So that's taken as the 100% of the cases. And then what this study does is go step by step through the access to a diagnostic center, to actually being diagnosed with tuberculosis, being registered for treatment, completing treatment, and having recurrence-free survival. And what this red circle indicates is that a total of 40% of the patients, of the estimated number of cases each year, actually doesn't get diagnosed. These patients either don't reach a TB diagnostic center, 28% of the estimated incident cases, or reach the center but don't have a diagnosis established, 12%. So all in all, 40% don't have the diagnosis established. Of those who are registered for treatment, 45% complete treatment, and 39% have a resurgence-free or recurrence-free survival. This is after 1 year after completion of treatment. So what you see there is that of the total number of cases each year, based on this assessment, only 39% were actually treated successfully. This is a more complicated analysis called the country pathway analysis. It's a series of studies led by Christy Hansen, who now is at the Gates Foundation, and is published in a supplement to the Journal of Infectious Diseases in November. What she did initially was look at care-seeking behavior, care-seeking patterns of patients, just in general, not TB patients, but where do patients go for care in these 13 countries. And she divided this up into the informal private sector, the red bar, the private sector in the blue bar, and the public sector in the brown portion of the bar. What she found was that about 39% of care seeking, initial care seeking, is in the public sector, 40% is in the private sector, and 21% in the informal private sector. Much of this in India, looking at care in non-qualified providers. She then divided these into different levels, level of availability of services, level 0, 1, 2, and 3. And as you might imagine, level 3 has the highest level of services. This was divided, this was seen both in the public sector and the private sector. The informal private sector was all level 0. So this is where patients go when they are sick, when there's something wrong and they're seeking care. Now, looking at the coverage of microscopy among those facilities that patients visit, she found that most of the level 3 facilities in the public and private sector have the ability to make a diagnosis of tuberculosis using sputum smear microscopy. About half of the level 2 facilities and a small percentage, very small percentage of the level 0 facilities had smear microscopy capacity. So that this works out then to about 19% of people seeking care in the public sector seek care in a facility that has the capacity to make a diagnosis of tuberculosis, and 10% of those seeking care in the private sector are seen in a facility that, again, has the capacity to make a diagnosis. And if you superimpose treatment, the coverage of treatment services on this, you see, again, that there are limitations of treatment services based on the levels of care that in the private sector, about 69% of the private sector facilities could provide TB treatment, whereas 67% of the public sector facilities could provide treatment. So the likelihood of a person entering care, being diagnosed as having tuberculosis and having access to treatment was only 7% in the private sector and 23% in the public sector. The point she makes with this on the side comment is that patients often circulate through this system several times because they don't have a diagnosis established with the first visit. They'll go initially to private sector, then to public, or to public, then to private, and back and forth. So they may circulate through this system a number of times before a diagnosis is established and treatment is started. Now, just looking at where these cases might be based on what we know of the case notification rates among the estimated burden of disease, 43%, this is getting back to the 40% gap that I mentioned, are not notified. It's estimated about 5% of private patients are notified, and more than 50% of public sector patients are notified. So there are problems both in public and private sector in terms of case notification, which means there are problems in assessing outcomes. We really don't know the status of these patients and how effective treatment has been. this leads to the estimate that about 48% of patients who actually get to treatment are treated successfully. 7% are treated, but the treatment is not successfully. And with 43%, we really don't have the information to inform the program as to how successful treatment has been. And it's thought that most of this 43% is likely to reside in the private sector, the missing case gap. So what are the issues that arise from the data from prevalence surveys and also from the cascade of care and pathway analyses? First of all, patients commonly aren't aware of symptoms. It didn't show in these data, but in prevalence surveys, a number of patients who have cough didn't report the cough, didn't seek any evaluation for cough. Secondly, access to high quality care is limited. Third, there needs to be integration of care with strong primary care services in order to capture the patients that appear first at a primary care facility with some symptom that could be caused by tuberculosis, and so that they can undergo appropriate diagnostic evaluations. The delay in diagnosis is thought to be one of the issues that contributes to transmission of Mycobacterium tuberculosis and perpetuation of the epidemic. We also don't know what the appropriate, most useful screening tests and algorithms are in determining who should be evaluated for tuberculosis, given that cough, the previous, the still current criterion that's used to prompt an evaluation for TB is not a very sensitive indicator of the disease being present. That the data also show just how poor the performance of conventional microbiological tests is. And as I suggested earlier, it looks in some of the prevalence survey data like the expert might actually be more sensitive than culture in practice. I didn't present the data that show the use of chest radiography in screening. What is clear is that radiologic evaluation is a very sensitive but non-specific way of identifying people who might have tuberculosis. It is very useful to identify those who require further evaluation with microbiological techniques. And finally, we really don't know what the epidemiological impact of asymptomatic tuberculosis is. Do those people who don't have cough yet have a positive microbiologic test transmit the organism? Are they important in the perpetuation of the epidemic of tuberculosis? This deserves quite a bit of consideration and investigation. So in terms of implications for clinicians from the data of the prevalence surveys and the pathway analyses, that the clinical suspicion for TB must be increased among those with risks that we'll talk about in a minute in high incidence settings, so that the clinician must always have in his or her mind that a patient presenting with very nonspecific symptoms might in fact have tuberculosis. And that symptom screening should be broadened to include not just cough for 2 weeks or more, but cough of any duration, fever, night sweats, weight loss. All of these should be grouped as a symptom screen for tuberculosis. Where possible, where the facilities exist, patients with symptoms should be evaluated with a chest X-ray, and any radiographic abnormalities that are suggestive of TB should be ideally evaluated with a rapid molecular test. And I think it's strong evidence that deployment of rapid molecular testing is a very important intervention to improve global tuberculosis control. And finally, communication and collaboration between the public and private sectors is essential. As you saw in the pathways analysis, there were about equal percentages of patients seeking care in the public and private sectors. And so the private sector must be viewed as an important part of a country's healthcare system. So that concludes this module, and we'll move on to talk a bit about clinical tuberculosis and some of the risk factors that are important in the global context.